Okay, good morning, everybody. It's my pleasure to give a speech to this meeting on infectious disease, so the World Congress in Infectious Disease in Boston. I've been in Boston 5 years ago at Boston University to give a speech on healthcare-associated infection, and it's my pleasure to get back again to this place. And I am going to present some new aspects of surveillance of healthcare-associated infection and the development of somehow new technology, which represent new challenges for the next decade. So no disclosure of interest. Let me first present the context of healthcare-associated infection in the general context of health protection against emerging infectious disease. As you can see on this slide, there are many examples. Of course, it's not all, but many examples of emerging infectious disease occurring for the last 3 decades. As you can recognize the cow here, which is not very healthy, which is responsible, as you know, of a cross-fed-Jacob disease in human. And also, sorry, the pointer is the pointer is here. No, maybe. What does it middle? Middle. Okay. I see. And also, of course, HIV contamination with blood transfusion in the mid 80s, I would say. And for maybe a century, the waves of influenza pandemic, and the last one was almost 15 years ago. And more recently, a huge outbreak in Africa, in West Africa, a huge outbreak of Ebola disease, Ebola virus, as you see, with very high potential for dissemination, including healthcare personnel. It's the reason why you see this picture with a sort of cosmonaut cloths on it. And more recently, as everybody knows, COVID-19 pandemic, which is not halted yet, and maybe we can expect that it's going to be better control in the near future. So all these diseases have something to do with healthcare-associated infection, in fact, because for instance, for blood HIV, blood transfusion, it's a healthcare. Or another example is, of course, COVID-19, which has been transmitted inside the healthcare settings, and also from patient to patient, but from patient to healthcare workers, and sometimes to healthcare workers to patients. And you know the discussion, the debate about the mask, of course. And after that, vaccination, but it's another issue. So it's the reason why I present that, because now we have to face with a world problem with healthcare-associated infection. I will develop that in detail in a few minutes. Let's get back first, before developing, let's get first to older age. And as you know, 2 centuries ago, to remind the history of infection prevention and surveillance in healthcare, which was originated by Mr. Semmelweis. As you know, everybody certainly, he demonstrated the role of hand hygiene in reducing maternal mortality here, and due to severe sepsis, of course, and following delivery. So these guys worked in Vienna, as you know, and he was a surgeon, obstetrician, and the hypothesis was the hand hygienes of MD students who were soiled after body dissection, and the reason why the maternal mortality was 3 times higher in patients, in the women with delivery with MD student and MD in general, surgeon, as compared to the facilities where there were only midwives. So they don't, of course, they didn't practice dissection. But so when the hand hygiene was down, the maternal death rate decreased significantly to the baseline, and there were no differences between those two groups. Now, let's go to the more basic concept of healthcare-associated infections, because it's not really a unique disease. It's a group of disease occurring under certain conditions. WHO proposed a current definition, which is adopted by everybody. And this is infection occurring in patients during the process of care in a hospital, but not only hospital, also other healthcare facilities, such as, for instance, nursing home, daycare center, etc. And that was not present or incubating on admission, including after discharge or also in healthcare staff, which is what remind you of the previous slide about the transmission between patient and healthcare staff. The second issue is that there are some conditioning factors for this infection occurrence, which combine, in fact, two things. The patient cares, especially with invasive cares, and also the pathogen virulence, which is generally not high in healthcare-associated infection. It's generally the microbiological flora of the skin, of the bowels, or respiratory tract, in fact. And the question of antibiotic resistance is also a subject, of course, for the efficacy of the treatments. The origin is most of the time, endogenous. So coming from this flora carried by the patient, but sometimes it could be exogenous too, with handborne, of course, handborne infection, and also through material in surgery, for instance, but not only, and more rarely from the environment. So prevention is based on reducing first endogenous flora with the disinfection process, but also reduce contacts with body fluids, with surfaces, with air. WHO provide a report which pointed out some very important issue about the impact of HI and antimicrobial resistance on people's lives. First, coming from a European country and related countries, the burden of the 6 most frequent HIs in terms of disability and premature mortality was higher, twice higher, the burden of other infectious diseases combined, 32 infectious diseases in this case. mortality among patients affected by healthcare-associated infection was almost 25%, 25%, and increasing, of course, in intensive care unit until up to more than 50%. And the mortality among patients infected with resistant microorganisms is at least 2 to 3 times higher than among those infected with sensitive microorganisms. So the impact of antimicrobial resistance is fully demonstrated. And the 3 most impactful antibiotic-resistant microorganisms, which account for the biggest part of this microorganisms, is 70% of the burden of AMR and are typically acquired in healthcare settings. And finally, it has been estimated that between 80 to 180,000 healthcare workers lost their lives to COVID-19 globally between the beginning of the pandemic and a limit and endpoint at May 2021. So the impact is real and very threatening. Let's now let's keep to illustrate this point. Let's first focus on European data. The frequency of HI has been determined by point prevalence studies that estimated the average prevalence at 6.5% in acute care, and just a little bit lesser in long-term care, around 4%. So one day there is around just a little bit more than 1 person to 20 who carry healthcare-associated infection in hospital in acute care. And this is corresponding to an extrapolation of about 6 to 8 million of HI per year in Europe. Relatively, these results comparing to the different countries are relatively homogeneous. Even there is some differences, but the interpretation is a little bit difficult because there is a difference in sample size among countries. So we cannot say exactly country by country that there is a huge difference. Let's now skip to the world level. At the world level, recent meta-analysis showed that for over 20 years period, there is, in fact, wide variation among countries, but also with the reserve, the limits that they could be misinterpretation due to the sample size differences. Apart to this methodological consideration, and according to the WHO regions, we can see, there is 6 WHO region. And in this slide, you have the African region, which has the highest point estimate, as compared to the American region, including South and North, and also West Pacific region, which had in this study, in this estimation, the lowest point estimate. And Europe, it's just intermediate in this case. So we can see there is true difference in this perspective of world HI. We have the difficulty to have standardized criteria to compare, but it seems to be different in some part of the world. The other things issue from the same study show that when looking at prevalence according to pathogens and also type of infection, you can see that the highest pathogen involved was Staphylococcus species, and also enterobacteria, including at first E. coli infections. And the four more frequent infection were first surgical site infection, and also urinary tract, respiratory tract, including pneumonia, and also bloodstream infection or bacteremia, which are very similar. It's just a question of definition. And in addition to that, Africa, as it's related to the previous slide, the highest rates for this pathogen and for this site of infection. Let's keep to this interesting study, recent collaborative study in surgery, including 66 countries and more than 12,000 patients that reported a significant relationship between the risk of surgical site infection, SSI, and the country development index. So as you know, the country development index is combined expectancy, life expectancy, education level, and income level of the country. And when you look at the results, which is a multivariate analysis, so adjusted for instance, risk factors of patients, as you can see, underlying disease, diabetes, immunosuppression, also antibiotic prophylaxis, and also the type of surgery and the technique, and the status, the infectious status of the surgical site of the operation. You can see that there is a significant risk, 1.6 in relative risk for low HDI countries. And this is the first study I see like that. Maybe there is others, but with I mean international dimension, it's interesting because we can really point out that the efforts which are made in I mean in developed countries have to be made also in developing countries. And so it's the reason why I show you this this study. Let's now focus on what about antibiotic resistance in the world. Also a recent review in almost 100 countries and more than almost 500 studies over a 10-year period estimates around 136 million a year the number of antibiotic resistance infection, which is called HERI here, over a 10 years period. So, and the most frequent pathogen involved in such infection, as you can see, were again enterobacteria, E. coli, Klebsiella, but also Acinetobacter, Pseudomonas, and of course Staphylococcus. And the relationship, as you can see, of course, in the crude rate of the number of infections per year is, of course, related to the number of inhabitants in each country. So it's normal that you can see in China, in India, or other countries like that with biggest population. But when you look at the rate of infections, you can see that medium income countries are the highest impacted by the problem of antibiotic resistance. And maybe it could be explained, maybe you will have some question about that, by the fact that they have antibiotics, but sometimes they have not the mean to better control the use of antibiotics and the stewardship, in fact, in antibiotic policy. Let's focus a little bit more on antibiotic resistance. On these slides, coming from a recent study in the Lancet, I chose two markers of resistance to illustrate this important problem, which are frequently associated with extended resistance to antibiotics. The first being Staphylococcus with resistance to methicillin, and the second is E. coli resistant to third generation cephalosporin. You can see on this slide that they are frequent in the world in many countries, including northern countries and southern or I would say medium intermediate countries in terms of geography, of course. And the other one is also frequent, maybe more concentrated in some part of the world, as you can see in Asia and Southern Asia, for instance, more than in the northern one. But this is a real problem, and they are so associated with extended resistance. They are also responsible for a heavy burden in terms of deaths, and they represent, it has been estimated in the study, about almost 5 million death-associated infection. And if we just look at the attributable mortality directly to antibiotic resistance infection, it's more than 1 million, 1,027,000 in this slide. And those two microorganisms are the first involved in this mortality, even associated and attributable. So it's the reason why we have to look very cautiously with these pathogens. And to complete that, the relationship between broad-spectrum antibiotics resistance, extended resistance, and the antibiotics consumption is shown on this slide. Indeed, it's important to consider that a better antibiotic usage is one of the two pillars of AMR control measures. Behind reduction of cross-transmission using hand hygiene, of course, and disinfection, as you know, it's important to control the usage of antibiotics. And Klebsiella is a good example of bacterial marker for emerging resistance with beta-lactamase firstly to cephalo. As you can see, I chose Klebsiella. With the first step is the third generation cephalosporin resistance. As you can see, it's now very widely extended in many countries. The red one was those with more than 50% of the strains which are resistant to that. Okay, so it's a little bit threatening. And the second step, I would say like that, is that the resistance of this Klebsiella to second line antibiotic, which is carbapenems, and now we have strains resistant to carbapenem, so it's not sensitive to other antibiotics. In fact, some new antibiotics try to combat, but it's not really the solution. And even if it's not very extended, we could have the feeling that maybe it's going to be more extended in the near future. And the reason is that if you look at this is another study directly issued from the WHO report on a panel of countries who were evaluated and participate to the International Network for Antimicrobial Consumption with WHO, so the GLASS project. And it shows, as you can see, that there is the beta-lactams consumption are the most consumed antibiotics, but also with combination with other. And if you look at, I don't want to do that country by country, but if you look at this country with the highest consumption, you can see that they are generally with the highest level of resistance to these antibiotics. Okay, so there is, of course, evidence that there is a relationship, even if it's not very easy to establish precisely country by country or area by area, but we have evidence that there is a relationship between consumption or overconsumption of antibiotics and resistance level. In France, we have 20 years of history of surveillance of this resistance. And as you can see on this slide, it is issued from the National Surveillance Network. This resistance incident is not a fatality, in fact, because you can see, for instance, for MRSA, for MRSA, you have a decrease, significant decrease over the 20 years period, and even with COVID-19 period, it doesn't seem to re-emerge. So it is a real decrease. Whereas for enterobacteria, especially with extended spectrum beta-lactamase resistance, which is plasmidic resistant, as you know, and can spread among bacterial species, not only among persons, but among bacterial species. You see on this slide, and we are not the only country with this kind of result, that until 2016, we have a significant increase of the bacteria, and after that, it seemed to decrease, even though there is a small surge in 2020, which is, as you know, the date of the beginning of the COVID-19 pandemic. But anyway, after that, it seems to be stable. I would say like that. Another reason for being encouraged to continue efforts is that there is other interesting results in terms of, for instance, I back again with surgical site infection. But we have to ask and to think about why some HI are decreasing, why other increase. It's a difficult issue and very difficult to understand the reasons. One of the reasons is the participation to surveillance network. As you can see on this slide, I present the partial results of collaborative study made in essentially in Europe, but not only, with also some countries from Asia and Australia, but generally high-income countries, and with more than 5 million operation, and meaning that it was around more than 100,000 surgical site infection. We evaluate the trends of such infection according to the year of surveillance, so the number of years of surveillance, or the year of follow-up, if you want. And you can see that there was a significant and regular decrease of around 35% for all procedures, and for also low-risk procedures. It was also significant, and reaching a sort of stability at 7 years of surveillance. But it is not exactly the same thing when we focus on some particular procedures, because as you can see, there is some which is very similar to the global results, but other, like for instance craniotomy or breast surgery, which are not really convincing in terms of decreasing. It is contrasted results, and so is but anyway, there is a true impact of being in a surveillance system for healthcare facilities. For instance, for this example, which is surgical site infection, but it could be the same for other targets of the healthcare control program, healthcare infection control program. Look now at this slide. So the issue is how to foster, in fact, healthcare facility to participate to HI surveillance. Because when we look at this, it's again issued from the GLASS report. This slide describes the implementation of antimicrobial consumption surveillance, and through a panel of countries who participate in this network. And as you can see, there is evidence that there are still many gaps and weaknesses. There is less than 50% of countries where there is no regular data collection or analysis, and no data feedback, in fact, but also you can see this example, no technical team which is dedicated to surveillance and to data management. So there is huge progress to do. Finally, and more generally, WHO has defined core components of IC programs that should be achieved. And you can see on the map the global results worldwide, which many countries are, with many countries which are far from achievement. You can see, for instance, these countries in red, but not only in yellow or orange. They are not, and there is strange, interesting results, not strange, sorry, but interesting results in other countries, like in the US, for instance, Europe, or other countries in Asia. But we have effort to do, and what are the reasons for that? On this slide, when we look at the specific core components, you can see that there is gaps primarily if we focus on surveillance problem, because if there is lack of expertise or problem of financial investment in the hospital, but also there is a problem of monitoring and feedback. And also the problem of workload, because not enough staff personnel to do the surveillance, and on lack of human resources, if you want, and dedicated to IPC activities in general. This is a plea, of course, for going to automation of surveillance using routine data with information technology, and this is the part now I am going to develop. Look first at, and let me explain briefly the challenge of automation, because we are living now around, we are surrounded by robots and automats and every kind of. The question is how to render these robots effective for human. It's probably the main challenge. As shown on this slide, there is two possible ways to use automation. First, it's just issued from a study published by my colleague, Dutch colleague Michael van Moerik in clinical infectious disease some years ago, and it's the presentation of the first data source is the electronic health record. So the medical file, the biological data, the pharmacy data too, for treatment, and which are filled in routine, and you can use it and try to select at the first step the high probability patient to have an HI, to have an infection. And this is the semi-automated. Why is it semi-automated way? Because the validation of the infection is made by a physician or eventually a preventionist or medical doctor, in fact, to say there is, and we determine the status of infection, yes or no, it is an infection. Of course, if the machine, if the robot just say low probability, there is no infection. So you can rule out a part, sometimes the most important part of infection, you can select, and you can rule out patient with no infection without having the spending time to determine whether or not they have infection, in fact. The second way is fully automated system, fully automated process with the same data source. But here it's an algorithm who determine the status on infection based of electronic health records, and there is no human intervention except for the fact that we have to discuss about it. That's not for selecting infection. So this system has been evaluated in a European project called PRIZE, and this is the PRIZE network with different countries in Europe, including mine, which participate to this project, and we try to evaluate what has been doing so far. And as you can see, the most frequent infection which are followed is surgical site infection, and also sepsis or other bloodstream infection, urinary tract infection, and central line bloodstream infection. To a lesser, with a lesser frequency of pneumonia or ventilated-associated pneumonia. So these are the four main infections which are surveyed with automatic system, most of the time semi-automated surveillance. And it is sometimes local, maybe most of the time, but it could be in gray, it could be also through a network in the country where it is done. So it's launched now. It's not even maybe so extended as much as we can expect, but it is en route, we say in French. Just look back with a study, pilot study we performed some years ago in France, to point out that with simple data we can have a relatively performance system. I would say that combining surgery revision procedures and microbiological samples at the lab in a hospital, validated with an infection control practitioner, make it that surgical site is possible. And the next step is the validation by the surgeon, for instance, and it could the possible change into certain infection. And this system has been evaluated in this study as relatively performing, as you can see, with good sensitivity and good specificity. And the time gained is more than 60% as compared to manual process. So it is really what we want to achieve is to gain time to skip other activities of infection control, not only to collect data and to count beams, as we say. Okay. In France, we have based on this first experience, we extended at the national level. So combining first criteria, reoperation and microbiology, coming from routine data from the health recording, electronic health recording of the hospital. So it's the first step automated. And after that, we select probable surgical site infection, which are secondarily confirmed by a surgeon. And the system allowed us to provide standardized reports for each hospital. They could import their data and the reports from an electronic platform using different kind of variables, different kind of data with, for instance, the specialty, the risk factors of the patient, the comorbidity, etc. So I don't want to detail that, but it works. We have a specific fully automated system using healthcare data from the hospital discharge, but it is not analyzed by hospital itself, but at the national level, and it just targeted on hip and knee prosthesis surgery. And as you can see, using an algorithm based on ICD-10 codes, we have a good sensitivity and a good specificity of this system. It has been evaluated and published in Infection Control Hospital Epidemiology some years ago. And also, the system provide, it is called ISO-Ortho, provide an annual report with benchmark every healthcare facilities, every surgical center, according to their incidence rate, standardized incidence rate of surgical site infection. And it allows to first present the results and detect what we called outliers here, which are at the upper limit of what it is expected. So the advantage and limit of automated HI surveillance, opportunity, first, we have the opportunity to benefit from the expansion of electronic health records and the development in general of information technology. For data collection, as I demonstrated just before, it could reduce time and resources which could be better used for IC prevention in other activity. And there is also potentially better acceptance by hospital teams. The reliability is good if data are standardized for interfacility comparison. And it is in real time, and it would allow to link data sets, different data sets from the hospital, and also for sometimes early detection and respond to an outbreak, for instance. But the limitation, as you know, is that in some settings, low-income settings, there is limited local access. HI definition could be sometimes need clinical validation. The example of surgical site infection, for instance. There is low quality of data source in routine, sometimes extracted from electronic records, so we have to validate that. And sometimes difficulty to access to a network that would provide tools for both for all settings. There is a problem of regulation with data protection, and also the loss of follow-up, because most of patients, for instance, in surgery, just stay 1 or 2 days or 3 days at hospital, and after they are out of. And we need, and I will talk about that just in this slide. And it's almost the end. This slide shows that we can extend e-technology to improve the efficacy of such automated system, not only in hospital, but outside the hospital to trace patients. For instance, I just, for illustrating with a study recently published, used the effort of the patient himself, and the patient makes his own post-discharge follow-up, in fact, and could detect his wound and take pictures with a specific app in his mobile phone, for instance. And this app could be enhanced in terms of quality of the image which have been taken by artificial intelligence. And in fact, it could be transmitted in real time to a surgical staff via an electronic platform. So this is the future, but of course, it has to be evaluated, and but it is not just a dream. It's a reality, and we know that some centers use that, for instance, for surgery, but probably for the infection. So in conclusion, I would say that surveillance of HI, especially those with heavy burden, is a key issue for many countries, as you understand. Automation could be an improvement factor for IC policy, but under condition of human and financial resources, which are probably one of the major limits. A wider acceptance of healthcare staff to use new IT tools could be gained through specific training and specific information. And I would say maybe for patients themselves, but sometimes they cannot use it because they are sick, they are old, or they have not the means to use this kind of things. And new technologies and processes, including AI, may help to enhance the effectiveness of HI surveillance in the near future. To conclude absolutely this speech, I'm not resist to present in the old age the history of John Grant, not his bio. I just make sure that it will be brief. But as you know, in the 17th century, he used the bills of mortality, so the death notifications, okay, which was done in routine, okay, not for health at this time. And so he used for survey the plague in London, okay? And he had the idea of analyze the death notification to select what case was associated with the plague and what case or what death was not. And this was the first step of the surveillance. It's what we as you know, probably, it is regularly mentioned in the School of Public Health all around the world. And the most important thing that using this simple data, he could edit a quarterly report and have back information, feedback to population, and to, of course, use data for public health and for control measure in this precise example. So I have finished. I would like to thank, of course, my team and every colleague who helped me to prepare this speech, and of course my students in France, and with supported by the different institutions who collaborate. So thank you very much for your attention. I'm ready to answer questions if you have.
One question.